disorders in children actually, it's a kind of like pulmonology, non-pulmonology, it doesn't have a rule book. So it was initially, the sleep disorders in children was actually more perpetuated into their hierarchy only by psychiatrists long time back. It started in America, and later it was actually borrowed on by pediatric neurologists. And halfway through, there were actually a good chunk of people who had sleep disordered breathing, and then it actually marched down into into pediatric pulmonologists. And then we have taken it in a big way, and that's where we are actually getting this topic into the pulmonology segment. I don't have any conflict of interest to declare. Actually, this talk is actually exclusively for pediatricians. So, aim of this presentation, I'm just going to touch upon topics which actually has got something to do, or like what a pediatrician can do, like screening for sleep studies, educating the parents, medications, what you shouldn't be doing in a sleep concern to or advising a sleep concern to parents. What I will not be covering will be sleep investigations, and any detailed system-oriented sleep disorders will not be addressed in this talk. It's actually a topic of its own, and then it gets a bit of more complicated when we go into that. So as I told you, like what's up in the branch, actually it's more of a pediatric pulmonologist who are doing more of the sleep work. However, like we can see more of pediatric neurologists also equally interested all around the world. And of course, like I have some of my very good friends in pediatric neurology in Tamil Nadu who are actually interested in sleep disorders. So we have very many limitations when we address to the pediatricians of what they can do, and those limitations will be evident in this talk. So how do we classify sleep disorders? Actually, just to make sure that like you are aware about the classification and the varieties of sleep disorders. It is just not about like obstructive sleep apnea. So there are varieties like insufficient sleep, fragmented sleep, sleep-related movement disorders, and then there are disorders where like you sleep more. There is central disorder of hypersomnolescence. So in insufficient sleep, we call it insomnia or circadian rhythm disorders. In fragmented sleep, you get it fragmented because of obstructive sleep and also by central sleep disordered breathing. In sleep related movement disorders, we have varieties, simple and complex. And then in the central disorders of hypersomnolescence, we have the narcolepsy and idiopathic hypersomnia. Don't get scared. I'm not going to bombard you with all these topics actually. So it is going to be very simple. So it was very difficult for me when I went through this classification to remember. Like I didn't understand any bloody thing. So types of sleep disorders to me is there are kids with less sleep, there are kids with more sleep. They have something kind of jet lag kind of disorder, or sometimes they do something what is unwanted during the sleep. So these are the four varieties which you can see in any of the children. So when you do a decision making, or like when you have a broad outlook of anybody who's going to come into a clinic of a pediatrician and then say, oh, I have a sleep concern, these are the first things. Either there is a suspicion or there is a presentation from the parents for the sleep concerns. You better do the screening, and then you classify it either into a sleep disordered breathing or a behavioral sleep disorder, because both these topics are a huge level of investigations which proceeds on after these been suspected, and then comes the sleep study. It's quite unfortunate that like sleep study as EEG, it's pretty complicated, and then it is not a very cheap investigation which is available everywhere. And that's the reason like the pediatricians cannot or take over that kind of investigations on a regular clinic, and it takes a bit of time actually like on that basis. To just go through what you can do in sleep disordered breathing, because like I'm not going to concentrate on all these topics actually at the moment. Like this particular slide will tell you what you know already on sleep disordered breathing. Either it is obstructive or it is non-obstructive. What we are going to do in obstructive sleep disordered breathing is about like either you go for a surgical management or you go for a non-surgical management. In surgical management, all you know is about like all you have been aware of is actually adenotonsillectomy, revision adenoidectomy, BBI surgeries. If it is going to be unsolvable, and then there can be situations where like you land up in tracheostomy. When it is going to be non-surgical, there is a lot of options actually with non-invasive ventilation and then dental interventions. When it comes to non-obstructive SDBs, again, this goes more into a long-term ventilation kind of care, and so we will not be looking into this in a detailed manner today. What can a pediatrician do? This is where we start the topic on. So, is there a sleep problem? And if yes, what type? Is the first question any pediatrician can be able to identify. It is actually quite simple as we can do it. So the normal baseline questionnaire, which actually is available to everyone, and then you might have been hearing this in many other talks, is actually the BARS questionnaire. What does the BARS questionnaire hold on for you? It's BEARS is an acronym for all the questions you have to ask. It is B is the bedtime issues. Is there any problem at all for your child to fall asleep, or is there any difficulty continuing the sleep? Is there E for excessive daytime sleepiness? And A for awakenings at the night time is the child starts to sleep very quietly, but like he gets aroused many a times in this whole night. Any regularity and duration of the sleep, is there any irregularity which actually happens? And finally, the snoring. Without snoring, we cannot qualify any obstructive sleep apnea. So naturally, like we have to have that component of snoring. If there is going to be anyone who wants to do the screener in their outpatient in Tamil Nadu, for parents who actually understand Tamil, I have completely translated into Tamil, and then I can circulate it after this meeting. And then if anyone wants to, please contact the TNSC office as well, and then they can let me know, and then I can share this. It's very, very simple. And then during the waiting period, like which actually is not going to be happening in this pandemic, but like if there is going to be anybody who is going to approach you to just ask for saying, can I say, doctor, like there is something disturbing in my child's sleep, and then you can ask them to answer these questions. Now, whenever parents approach, either they ask for, either say that like my child is snoring, or like my child has got like disturbed sleep all through the night. More than that, like I usually hear any infant who's actually like less than 1 year mothers or fathers who come back to say me that like ஏன் குழந்தை தூங்குறதே இல்லைங்க. இட்ஸ் வெரி 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 ஆப்வியஸ். நீங்க சொன்னா நம்ப மாட்டீங்க டாக்டர், இந்த 6 மாசத்துல என் குழந்தை தூங்குனதே கிடையாது. And it's very hard to believe them, and then you start actually anything like investigations at all. So we definitely need a sleep diary. They have given you a difficult question, so you can give them a difficult task as well. So ask them to plot all the hours of sleep for about a month, minimum a month actually. Some of my patients actually have been doing this on a regular basis, which is very fantastic actually. So it gives a fantastic profile of what kind of sleep and what timing of sleep is the child going through, and then it is evolving through as well. It's quite easy to mark this. This is one of my patients who have marked it actually. The parents have been very sincere in doing that. If you fold this paper right at 9 o'clock into half, it will turn into the folded upper part will become the day, and then the folded down part will become the night. If the night is completely painted very well, you know that like the child is actually sleeping very well. If the day is being painted with patches of all these things, you very well know that like the child is having an increased daytime sleepiness. Depending on the age, it may be abnormal or normal. But with this, what I do have a small report which I generate. So it is a diary analysis which we can do. The number of days of sleep, the start time and the end time of sleep, amount of disturbed nights, and then the recommended hours, is it breached or not breached, and all this stuff. It's a very simple and then fantastic tool. There are varieties of sleep diaries available on the internet, and this is my own. With this, we can say that like whether there is going to be a normal timing of sleep. But then when they say that like we can tell them saying that like no, your child is in range or like a little breached out of range, and then you can decipher from that. But do we have a normative value? Only American Academy of Pediatrics has given and then published this. There had been some previous reports from Canadian Academy, Australian Academy as well. But however, like this has been very well studied by Dr. Mahesh Babu in Singapore actually, and then he came back with an answer saying that like, see, this is more ethnic. It is not actually like we cannot stipulate this with actually an American guideline or the timing of sleep. But however, like we are happy to follow this number of hours actually. So it gives a range, it gives a fair idea about like how many hours of sleep for any particular age, and you can see that like it grows down, and then naturally like there is less and less of sleep when we grow more older. Then comes the screening questionnaires. So the first is actually about like if there is going to be a bears questionnaire, and then if the parent says like some of the questions which actually are like some of the components which are going to be positive, then we can proceed on to a sleep questionnaire itself. What are the available questionnaires? All these questionnaires are free of cost. So there is a child sleep habit questionnaire which can be used, and there is another questionnaire which actually classifies a variety of disorders. Why are these actually gaining more importance? In fact, when I had to talk on only questionnaires, I found a book which had 150 sleep questionnaires for children. Just believe me, like it is actually there are 150 sleep questionnaires there available for children, and I picked only two of them actually because like these are the questionnaires which has been validated very well against many of the studies. And then this particular questionnaire is from Jody Mindel and team, who's actually in USA, like who are quite an authority in behavioral sleep. So it is a 33 item. It's quite like it takes around like 10 minutes for them to fill. It's only validated from 4 to 10 years, but they are doing even extremes of age now. It classifies the sleep into 8 particular classes, and then it is quite easy to use. I can share this with the calculator which I have made on an Excel sheet, which actually eases your job to interpret on this. This is actually the questionnaire, and then it takes around like 10 minutes and I can finish it off. And probably like you can classify the sleep into whether it is going to be a sleep disorder, breathing, narcolepsy, or like any type of other disorders which can be classified. Similarly, there is something called sleep disturbance scale for children, SDSC. I probably think like currently there is a PG thesis which is going on in SRMC right now on this particular scale, and they are trying to classify the available children with their complaints and then see what kind of sleep disorder they are belonging to. Very similar one in 27 item, and it looks like this. We have a scoring sheet, and then the scoring, the normative values which can be given, and then it can classify you and then give you a very fair idea about it. Now, when we classify that to be a sleep disordered breathing, then we have another questionnaire which can go into to see that like what level of sleep disordered breathing it is. So one is actually the pediatric sleep questionnaire, which the world knows forever actually. So it is a very elaborate questionnaire. It goes for about like 4 pages, which again is like a very nice component to fill, but like it definitely takes a bit of time. It's a pain actually. And then there is a smaller component in that is actually the sleep related breathing disorder scale. Now, this last bit of questionnaire actually carries more value. The reason why I'm saying it, like it is the only questionnaire which has been tested against polysomnography to identify obstructive sleep disorder breathing, and it has got a fantastic positive predictive value, underlying positive predictive value. When it scores more than 30%, it has a it has a 21 item questionnaire actually. 21 questions are there, and that's the questionnaire. And then if you score 7 or 8 questions to be yes or more than that, it carries more value that like when you do a polysomnography, you will have a positive result. However, if it is going to be negative, it cannot say anything much. So naturally, we have to go on and then prod on with individual approach. So videos are very common these days. Videos are fantastic these days. And then most of the parents have got a beautiful recording of any event during the night time. I sincerely appreciate that. And then this is more often is a very important modality which needs to be taught to even like this the medical students, like in the history, what is the video history kind of thing. So in sleep, it actually is quite important, very effective to describe the condition, and also a pilot to video somnography. Now I'm talking about something, a new term called video somnography. We know polysomnography, we know cardiorespiratory polygraphy, but what is video somnography? This is actually a tool which is evolving, and I'm sitting in the city where like there is a hospital nearby which is called the St. Mary's Hospital, who have done some work on this video somnography, and they have some qualifying components for the whole night of video. Actually, you just need to get the video of the child sleeping for a night or a sequence of nights, and then we can score on many things and then say that like what kind of disorder will the child belong to. There are several components, variables like sleep onset time, sleep night duration, and then wake after the sleep onset. VASO is actually a very important indices now. Morning rise time, night walking, and then several other parasomnias can be beautifully recorded, which cannot be done by polysomnography, which is actually a fantastic component. Okay, so you have screened the child, reasonable number of screeners and then questionnaires are available. What do we advise the parents? I'm deliberately skipping this main important part of investigations, which is sleep studies, which is not actually a common investigation available anything be nearby your vicinity. But however, like it is a very important component, as I mentioned in the first slide. There are only very few sleep concerns which doesn't need a sleep study. Now, when it comes to behavioral sleep issues, it's always the pediatrician who actually takes the first step. Sleep hygiene. Any number of times we can talk about this about like any number of times. Do we all have a sleep hygiene? Technically not. Actually speaking, like we are all like very unhygienic about sleep, including myself. Sticking to the same time of bedtime and wake time. Come on, like I never do that. Beds are for sleeping. The last thing anybody will follow through. I'm sure like every bedroom, like or like most of the houses with bedroom will have a electronic gadget which is sticking out there. At least a phone to watch. A comfy and cozy room. It's not a it's a luxury actually in Tamil Nadu. Like you cannot ask all the parents to have a comfy and cozy room. Like they live in one room actually most of the time. Alarm clocks are for waking up and it shouldn't be disturbing the sleep. Bedtime routine, quiet and calm and relaxing activities, which is not watching uh, teleserials before you sleep. Teaching relaxing techniques. Start the day off right with exercise. Of course, yes, like exercise in the morning is the best. Avoid caffeine late in the evening. Of course, yes. There are many other caffeine containing drinks than coffee itself. If you can't sleep, get out of the bed, which actually is a very sincere and then good practice. Put the kids to sleep when they are drowsy but awake. Don't just carry them as they are sleeping, which actually is not the best thing to do. You know why when I'm going to talk about the infants in another few slides. Cuddle with a stuffed animal or a soft blanket. This is actually a controversial advice. There is a very high chance of sleep association, which again I'll be talking in next few slides. Maintain a sleep diary, which actually is very important when you are actually thinking about a sleep concern. Infants, the most talked about problematic segment in sleep. I don't think like no pediatrician will be left alone without a parent with an infant coming in and then saying about ரெண்டு விஷயம் தான் சொல்லுவாங்க. ஒன்று என் குழந்தை சாப்பிடலன்னு சொல்லுவாங்க, இன்னொன்று என் குழந்தை தூங்கலன்னு சொல்லுவாங்க, which actually is a very common complaint. So which is normal. Like my kid did it actually for some time. However, we have to make sure that like see behavioral insomnia, forget about the behavioral adjective, insomnia usually is not considered as a component or a diagnosis or an abnormality if it is going to be a less than 6 months old child. It's very normal for a polyphasic sleep. Polyphasic in the sense like ஒரு நாளைக்கு 10 தடவை தூங்குறது, which is very normal for infants and particularly less than 6 months. And we cannot say that like இல்ல இந்த குழந்தை தூங்கல அல்லது there is an insomnic component in a less than 6 months old child. Very unlikely. Very unlikely. Infant sleep is addressed based on only these three components. Take it and then just memorize it and then keep it in your mind. And I probably think like this will be helpful for any pediatrician to say. Are the parents finding the cues for sleep? Is the child going to sleep? Can a parent find that like the child is going to sleep? The second component. Is the parent pampering the child? Literally, அழுதாலே கப்புன்னு போய் தூக்கிக்கிற பேரண்ட்ஸா இல்லை எந்த நேரமும் தாமேலேயே தூங்க வைக்கிற பேரண்ட்ஸா அல்லது அந்த குழந்தையே தூங்கட்டும்னு விடுற பேரண்ட்ஸா? The self-soothing techniques, how far have they achieved? An entraining day and night differentiation, which is very important. Actually, this happens in course of time. But however, like எந்த நேரம் வேணாலும் என் பிள்ளை தூங்கட்டும்னு நினைக்கிற அந்த type is not actually great. Now, the problem comes either in sleep initiation or sleep continuation. What are we going to advise in sleep initiation? எந்த குழந்தையா இருந்தாலும் ஒன்று பொம்மை இருக்கும், இல்லை பாட்டு இருக்கும், இல்லை அந்த பர்டிகுலர் பெட் இருக்கும், இல்லை அம்மா அல்லது அப்பா பக்கத்தில் இருப்பாங்க. ஸோ திஸ் இஸ் ஆக்சுவலி கால்ட் அ ஸ்லீப் அசோசியேஷன். The problem comes is whenever they get associated with the start of that sleep, they cannot get out of that when they are awakened in the middle of the night. திடீர்னு அந்த குழந்தை கையில் ஒரு டெடி பேரோட தூங்க ஆரம்பிச்சது அப்படின்னா halfway through the night அந்த டெடிவேர் பொத்துன்னு கீழே விழுந்துருச்சு அப்படின்னா திடீர்னு நடுவில் எந்திரிக்கிற அந்த குழந்தைக்கு டெடிவேர் இருந்தாதான் திரும்ப தூக்கம். That is called sleep association. That needs to get out of that, completely taken out of that. That is being achieved by extinction. பொறுமையா தான் செய்யணும். It is actually like there is unmodified extinction where children will self-soothe and then sleep away. Parents கண்டுக்கவே கூடாது. The second is graded extinction, and then there is a parental presence extinction. Parents will help it out for some nights and then they will stop after some time. Frequent awakenings. How do we address that? Like என் குழந்தை தூங்கிடுதுங்க, அதை பத்தி ஒன்றும் இல்லை. பட் ஆஃப்டர் சம் டைம் லைக் இட் ஷீ லைக் எவ்ரி டைம் ஒரு மணி நேரம் தூங்கினா மறுபடியும் எழுந்திரிச்சிக்கிறாங்க. ஸோ this needs to be addressed only when there is going to be a sleep diary which is showing less amount of sleep. That is where we are coming in here. Scheduled awakening and then preemptive waking schedule. These are methods to do it, and then we have something called a sleep coaching classes which has been taken by experts in Western countries. Of course, like I'm seeing that to be started in Bangalore right now, which are being trained to the parents. Scheduled awakening panla, or the preemptive waking schedule can be done as well. If it is going to be more than an infant, 2 to 6 year old, there is a only problem. படுக்க வைக்கிறதுக்குள்ள உயிர் போயிருது, வீடே ரெண்டாயிடும் சார். இது யூஷுவல் காம்பனண்ட். It's limit setting actually. So the child will set the limit and then the parents will budge to it, which actually is not great. So this has to be there. Like you have to sleep at 9 o'clock. It will be time at 9 o'clock. And then if it is going to be prolonging, நீ ரூம்ல படுத்து தூங்குப்பா, நான் முன்னாடி ரூம்ல போய் டிவி பார்க்குறேன், அது சரியா வராது. That cannot happen. Parents have to behave with the good sleep hygiene. That is what is coming in. We cannot only teach sleep hygiene, you have to model. The parents have to model as well. Night time fears, of course, yes. Like in the சமயத்துல தான் அந்த நைட் டைம்ல பேய் பிசாசு பயம் எல்லாம் வரும். அந்த சமயத்துல they cannot sleep alone, and there comes like the immediate solution is அம்மாவை கட்டி பிடிச்சி தூங்குவா, அப்பாவை கட்டி பிடிச்சி தூங்குவா. Very normal actually. It's a very normal thing. I did it actually. So co-sleeping is the start of another big problem. You cannot get out of co-sleeping. Co-sleeping is allowed in Indian culture actually in the same room. So I will not stop co-sleeping if the parents and the team or the family is comfortable. தென்னட்ல தாத்தா பாட்டி கிட்ட தூங்குற குழந்தைங்களும் இருப்பாங்க, which is actually fine. I don't disagree with that. But however, when it becomes a problem, when it actually only has to happen only with the parent or தாத்தா பாட்டி திடீர்னு ஊருக்கு போயிட்டாங்கன்னா என்ன செய்யறது அந்த சமயத்துல, then comes the relaxation techniques and then systematic desensitization and imaginations and creativity to draw a monster. இது ஒரு நல்ல பயிற்சியா இருந்தது ஆக்சுவலா. இப்போ இந்த குழந்தை எதை பார்த்து பயப்படுதோ அதையே படமா வரைய சொல்லணும். அதுக்கப்புறம் அதுக்கு ஒரு லெட்டர் எழுத சொல்லணும். You write a letter to that monster saying that like don't come tonight and then don't disturb me for my sleep, which actually has worked very well actually. It looks a little funny but it works. If it is going to be a little elder child, 6 to 11 years, usually they try to form a pattern of sleep. 10 to 11 hours of sleep is very normal. Progressive shift of sleep onset time மெதுவாக தள்ளி போயிட்டே இருக்கும். 8ல தூங்கினவங்க 9 ஆகும், 9லேருந்து 10 மணி ஆகும். They get delayed slowly. Sometimes they become a night owl. Some people become a morning lark. So they always call it. Like காலையில் 4 மணிக்கு எந்திரிக்கிற குழந்தை ஒன்று இருக்கும். சில குழந்தைங்க நைட்டில் 10-11 மணி வரைக்கும் தூங்கவே தூங்காது. அந்த டைப்பாக இருப்பாங்க. But they sleep the normal duration. That is for sure. So the limit setting will change into the hands of the child. The child has to set the limit for themselves. இன்னைக்கு எவ்வளோ டிவி பார்ப்பேன்? How much time will I spend in homework and then on the internet? And then faded bedtime. And then you can say that like, see, if you don't feel like falling asleep, don't go to the bed. But if you go to the bed, like make sure that like you sleep within about 15 minutes time. 15 நிமிஷம் தாண்டுதா, get out of the bed. And then make sure that like you do something else and then get back to your bed. That's important. Faded bedtime with the response cost. That's what I said. Like you have to resume after a break actually. You have to come back to the bed later. Of course, yes, like again, 6 to 11 இருந்தாலும் there is actually a predisposition for darkness, ghosts and everything, and then that also actually causes a problem. We have cognitive behavior therapy for that as well. Adolescents, they are their individuals of their own. நம்ம control இல்லாத age group, very tough. Don't think that like actually they are delaying their sleep just because like they like to do it. It is by their biology actually. There is a delayed release of melatonin which is happening, and there is a social availability of gadgets. அப்பதான் friends கிட்ட பேச முடியும், நிறைய chat பண்ணுவாங்க. So those things happen, and then the television, video games, everything actually takes a place in their life. Of course, yes, like increased amount of time in the bed actually is very, very, very problematic actually. They just toss in the bed and then they don't sleep at all. Sometimes in the adult diagnosis will come into adolescence group as well, psychophysiologic insomnia. It's nothing special illa. they cannot sleep in the bedroom, but they can sleep in a chair, in the front room, balcony, எங்க வேணாலும் தூங்கலாம். பட் அங்கெல்லாம் தூங்குற மாதிரி ஆரம்பிச்சாங்க அப்படின்னா then it is called actually psychophysiologic insomnia. If you put them back into the bedroom, they cannot sleep. அது ரொம்ப கஷ்டம். இந்த ரஜினி படத்துல காமிக்கிற மாதிரி ஒரு கட்டாந்தரையில தான் தூங்குவார் அங்கிருந்து, பட் பெட்ல போய் படுத்தா தூக்கமே வராது அப்படின்னு சொல்லுவார்ல, அந்த மாதிரி டைப். Remedies, sleep hygiene, relaxation techniques, again the same holds actually with all this stuff. Medications, this is the last bit. So I see that like there is a lots and lots of medications coming into play in sleep disorders amongst pediatricians, which is a welcome ground. Actually, it actually indirectly means they are actually trying to address these sleep issues. But what are the medications available? If you see the list of medications which are available, you will be stunned. There are many types and then many varieties of medications which is available in the books and in the market. But there is only one medication which has been well studied, melatonin. Nothing else. Where in the medicine for the purpose of sleep has not been studied in individuals or in normal individuals, I would say. There are neurodevelopmental problems which need special drugs, but that is actually not included into this. So normal children, when they cannot sleep, not everyone needs melatonin. That's important. Endogenous melatonin is a very normal hormone. It is actually synthesized from tryptophan. So melatonin is not actually a medication. It's nothing wrong in that. It has got a circadian rhythmicity and higher levels before when are you going to approach the bed or like the night time, and then it actually is very less during the daytime. The sunlight and then the light intensity will actually make it secrete or not secrete at all. Dose is 1 to 3 milligrams. It usually starts to act around like by 30 minutes. Ideal will be, that is the timing you have to think about. Like you cannot 10 மணிக்கு தூங்கணும்னா 9 o'clock எடுத்துடணும் அந்த மருந்து. அதுக்கப்புறம் எடுத்தீங்கன்னா 11 மணிக்கு தான் தூங்குவாங்க, அந்த மாதிரி டைப் ஆகிடும். So melatonin reduces sleep onset latency. This is to be stressed. Please note that like melatonin saapta, they cannot sleep all through the night. It is very, very, very impossible unless you take a sustained release tablet, which is available only in specific formulations. I don't think like anything have started available in India. It is only available as a tablet. That's இன்னொரு பெரிய difficulty. Not all children are very comfortable with tablets, and so they have to use this syrup, which actually is not going to give sustained effect. Sometimes in some of the neurodevelopmental problems, which I will be addressing about autism in the last slide, you can have a second dose in early morning, 2 o'clock. So to advance the sleep-wake pattern, smaller doses are to be started. Jet lag is only the problem. You just want to advance the sleep phase. You don't need a heavy dose. It actually is a very small dose which can work. Melatonin is actually a synthetic analog, which is almost like creeping into Indian market. No, it has not been approved for children, not yet. Now I'm just going to present like what is going to be a melatonin prescription pathway, which actually is very, very like very new for anyone to see that like melatonin edukku pathway அப்படினு பாப்பாங்க. Please note that like these are the criterions for prescribing melatonin. If a child comes with you like படுக்க வச்சு 30 நிமிஷம் ஆனதுக்கு அப்புறமும் படுத்தே தூங்க மாட்டேங்கிறாப்ல அப்படிங்கிற மாதிரி இருந்தாலும், and if it is going to be like daytime fatigueness or attention difficulties, and then this actually means that like there is a reduced amount of sleep, and then the parental opinion like எனக்கு நிச்சயமா எனக்கு ஒரு மருந்து கொடுத்துட்டா பரவாயில்லைங்க டாக்டர் அப்படிங்கிற நினைக்கிற டைப்பா இருந்தா then we can take it. The problem is like where do we stop? This is actually the target outcomes. The sleep latency reduce ஆயிடுச்சுன்னா try to stop the medicine after particular period of time, and then the total sleep time and then the longer sleep period, like those things actually gets into place, then you can stop that medication. Initiate melatonin in 1 to 2 milligrams. That is 30 minutes before the agreed bedtime. But I have to tell a thing, like you cannot start melatonin to be given something like என் குழந்தை 8 மணிக்கு தூங்கிட்டா பரவாயில்ல அப்படின்னு சொல்லி 7 மணிக்கு கொடுக்க கூடாது. அது ரொம்ப கஷ்டம். அது ஆக்சுவலா the child usually was sleeping at around like 11 o'clock. Now you cannot start it at 7 o'clock. You have to advance it by each and every hour. If your child has to be sleeping at like some point of time, start it at like 9 o'clock where the child will sleep at 10 o'clock. After about a week, move it to 8 o'clock and then you can make her sleep at 9 o'clock. அந்த மாதிரி தான் செய்ய முடியும். It is a natural phenomenon. நம்ம பாடி அவ்வளோ சீக்கிரத்தில் மாறாது ஆக்சுவலா. இல்லைன்னா ஜெட்லாக்ல நம்ம பைலட்ஸ் ஜெட் பிளேன் டிரைவர்ஸ்லாம் ஈஸியாக அதெல்லாம் மாற்றிடுவாங்க. It is not possible at all. Assess improvements in 1 week time actually, and then make sure that like if the dose is adequate, leave that actually in the same dose. Don't change it. Now annually, ஒரு வருஷம் ஆனதுக்கு அப்புறம் you have to just give a break. You have to have a break in melatonin. If that break is evaluated and then the child sleeps very well, then leave it off. If there is going to be a problem, you have to have two pathways. One is the basic dose. Once again, the original dose மறுபடியும் வேலை செய்தா இல்லைன்னா incremented dose மட்டும்தான் வேலை செய்தாங்கிறத பொறுத்து இருக்கு. If there is going to be no effect on the smaller dose, they are actually fast metabolizers. And then if there is going to be effect on the smaller dose, go back to the smaller dose and then you can go on with that. Now, if there is going to be no effect after increasing the dose until 6 milligrams, mark it 6 milligrams, and beyond 6 milligrams, it's usually in the hands of specialist, the sleep specialist, to increase up to 10 milligrams, which is a bit risky because like it gives an anticlimax effect. It actually reduces sleep after some time. So that needs to be considered. If it is not, please discontinue melatonin. It is not going to work at all. This and all has to happen within about like 3 to 4 weeks time. Sleep problems in autism. This is a special concern because like we are seeing autistic kids, and then autistic kids are sometimes like ADHD kind of kids. The sleep problem becomes the reason for the whole behavior, or the behavior actually causes sleep problem, mutta kodi kind of thing. So mostly associated with behavioral deterioration. When they are actually not okay during the day, actually there is a problem at the night time. It will be very interesting to see. I diagnosed an autism child at 8 months of age because the mother presented with a sleep problem and later behavioral concerns. And by around like 1.5 years, the child was a full-blown autism. The sleep issues can be a presenting symptom for autism. It's very, very new. It is possible. Common pattern, there is an offset in circadian rhythm. They cannot sleep in the particular period of time, or like frequent awakenings. இது ரெண்டு தான் நடக்கும். All the books all around the world, autism training network or like any guidelines, nice guidelines, in the guideline எடுத்தீங்கனாலும், there is only one thing which is being presented as the treatment: behavior therapy. Please do behavior therapy as the primary, and if you fail, go for melatonin. If you have or refractoriness to melatonin, we have other drugs like zolpidem and esclopicin, and a lot of things actually can be used in this children actually, and that actually takes a second seat. Now there is always a question about like the antihistamines will come in that cold medications sometimes for these kids also. இவங்க சளி பிடிக்கும் உடனே antihistamines போயிடுவாங்க. The problem I have seen is like as soon as the antihistamine is started, within about like 1 week time, the whole behavior completely distorts, and then they behave completely like the parents feel literally very deprived. சார் நல்லா இருந்த பையன் சார், நான் இந்த மருந்து கொடுக்க ஆரம்பிச்சேன், அதுக்கப்புறம் ரொம்ப மோசமாயிட்டான் சார் அப்படின்வாங்க. ஸோ antihistamines actually has got a very fantastic predisposition for sleep alteration, and then that actually disturbs their future sleep as well. Try not to use antihistamines as a or like try to avoid it actually completely. Right, இதெல்லாம் do's. இப்போ don'ts. Don't step on all these things. Apnea monitor வெளிநாட்டில் அவைலபிளாக இருக்கு. இந்தியாவில் sophisticated parents have started using apnea monitors and then see that like my child தூங்குதான்னு தெரியல சார், தூங்கும்போது ஏதாவது மூச்சு விடுறதுக்கு பயமா இருக்கேன்னு சொல்லி நான் apnea monitor வாங்கினேன் அமேசான்ல. No to it. It actually gives rubbish results. Home oximetry monitoring, finger oximeter, everybody is using finger oximetry, and then it is going to be there for children forever. இது அவாய்டே பண்ண முடியாத ஒரு ப்ராப்ளம். It's going to supply no data at all. It is impossible for them to download, understand what actually is a REM and non-REM based breathing, and saturations can happen. All these things are problematic. Sleep studies which you can't score. Remember, வெளியில நிறைய கடைகள் ஆரம்பிக்க போகுது சீக்கிரமே. It will start. There will be more sleep studies which will be coming into your front. If you can't score, if it is an automated score, please don't believe it actually. Sleep monitoring devices. This is new. Apple company has introduced this Bedit 3.5. Apple phone you can monitor how you are sleeping. The most useless gadget I've ever seen, and then it is actually been graded as the worst product from Apple itself. Ballisto cardiography அப்படிங்கிற technique, there will be a small strip underneath your bed, and then you have to only sleep on the bed to score the sleep. There are many other companies which has come. It's been proven that like it is absolutely not useful. It is only a fashionable device. Never for it. No melatonin for all. And sometimes this is cultural. Sleep associationsல rocking, துளியில பெச்சு ஆட்டுறது அப்படிங்கிறது வந்து is a sleep association. it's quite ஒரு மாதிரி it's a very dicey area. I wouldn't start with advising against rocking the child to make him sleep. If the child is actually sleeping in the thuli for a very long time, and which is acceptable, I wouldn't argue against for that to be avoided. Sometimes கிராமத்துல that actually is a protective mechanism. எறும்பு பல்லி பூச்சி பாச்சை தேள் இதுல இருந்து காப்பாற்ற போறதே அந்த தூளியா இருக்கும். So beware of these sleep associations and then keep off and then don't advise against it. And that's where I end. Sir, you are muted, sir.
Unmute பண்ணிக்க சார், விஜய் சேகர் சார் அன்மியூட் பண்ணிக்கங்க. Yeah.
Yes, sir. Can you?
Yes, we can hear you, sir.
I